I am trained as a pediatric intensivist. Well, why would an intensivist be teaching general pediatrics? Well, I was a general pediatrician before I became an intensivist, okay? I did general pediatrics for 7 years. I've been doing the Kaplan course in one way or another for like 20 some odd years now. Over 20 years, I've been doing either Kaplan or its predecessor. And currently, I am the medical director for the Hoops Children's Hospital in Huntington, West Virginia. There are small vesicles with crusting, short pants. It kind of means that there's some kind of exposure. So that's why some of you wrote contact dermatitis. There's contact, all right? But he's also, what's happening here is he's probably getting scratched. He's probably getting scratched when he walks. Many times, for example, we will see impetigo in children with eczema. Children with eczema or atopic dermatitis, it itches, and so they scratch and they break down the skin. What kind of germs live on our skin? Staph and strep, the kind of common causes of impetigo. And so that scratching from their itch can cause impetigo. Children with chicken pox itch, and they can scratch and get secondary impetigo. So you weren't far off, okay? Honey brown crusted lesions on an erythematous base. And look, I know that's not his legs. I know that's not his legs. You can't fool me. I'm a doctor. But this is what impetigo looks like, okay? Honey-colored crusting lesions. And you will get, on step 3, they're starting to give pictures and x-rays and EKGs and murmurs and all kinds of stuff because all the technology, right? Right. All right. Well, there's the differential diagnosis that many of you have already addressed in your answers there. Impetigo is at the top of the list. Now, cellulitis and erysipelas do not cause crusting or open sores. Cellulitis is red and it's warm, okay? Maybe raised a little bit. Erysipelas are even deeper layers, but there's no crusting or anything with those. Chickenpox can mimic impetigo. Folliculitis can cause, usually it looks like a pimple, all right? So there might be vesicles, actually more pustules, and there's going to be a hair growing because that's why it's called folliculitis, because of the follicle. Herpes simplex can mimic impetigo, and it can be more than just 1 or 2 lesions. Scabies cause a lot of itching. Scabies can lead to impetigo because you scratch a lot. With scabies, you'll see, however, burrows between the fingers, the webs, okay? And you can see the burrows here and all. Poison ivy, look for an exposure. Look for an exposure. And of course, eczema can also cause scratching, which can lead to impetigo. So the clues here are going to be the crusted lesions on an erythematous base. Like chickenpox, you can see various stages of crusting and openness, but usually you don't see pustules. You don't see macules, papules, vesicles, pustules. All right, this patient is an outpatient. You don't need to hospitalize these kids, and it's a clinical diagnosis. The exam, once again, what they're testing you on is, yes, knowledge, of course. And how are you going to manage patients? One of the things they look for is how logical are you? What is your thought process? Okay, that's one thing. How efficient are you? How cost effective are you? Okay, you can culture this up. You can do all kinds of stuff, but that costs money when you kind of know what it is just by looking at it. You don't always have to get a culture. You don't always have to MRI your patient or open them up, okay? Many times you can make a diagnosis by looking at the patient, asking a few questions, and examining the patient. This is one of those cases, okay? You do not need to do any cultures. Think of strep, think of staph. Doesn't matter which one it is, you're going to treat it anyway. You're going to treat it anyway. So let's try to be cost effective here. Let's try to not be invasive, drawing labs and all. These are classic presentations of impetigo. There's probably been some scratching, or he's been walking in the woods, and as he walks through the woods, there's some skin breakdown. The fact that he doesn't have a fever, that he doesn't look sick, that they said the rest of the physical exam is normal, means that it's probably a benign disease. Okay? Now we just briefly mentioned folliculitis, and so you have to look at the hairs. And look for folliculitis, look at the hairs. Where is the hair coming like through the lesion? And there's a picture coming up. Okay? And then you think about staph. But even with impetigo, think about staph, think about strep. In this particular case, like I said already, there's not deeper layers. It doesn't feel thickened. It's just these discrete lesions. Part of your differential diagnosis can be what's known as staphylococcal scalded skin. These patients look really sick. They look like they've been burned. You can have a Nikolsky sign, positive Nikolsky sign with staphylococcal scalded skin. That's when you scrape, you just stroke the skin and it starts to blister up. Okay, you won't see that with impetigo. These patients look a lot sicker. Okay, they can have massive fluid losses if it's a big area. This particular patient does not require any more treatment. That's right, Giselle, they can be septic. Okay? This patient does not require any more workup. You just need to treat them. Mupirocin is the drug of choice. Topical mupirocin is the drug of choice. Now, the little pearl for you, you have to know generic names of medications. They're not going to ask you for brand names. So mupirocin is the drug of choice. How the other, like these bacitracin, neomycin combinations that are advertised on TV over the counter, they just don't work as well. So we want to use mupirocin. It is prescription. If it is a big area, okay, you don't want to be like putting it on like you're frosting a cake. Okay, so if it's a big area, then you want to do oral antibiotics. In this day and age, always pick staph coverage. Always think of MRSA. So actually, clindamycin would be a really good choice orally for this. Or you can probably get by with like trimethoprim sulfamethoxazole. But always think of MRSA. All right? So you've got a pearl there on page 8. We don't use vancomycin orally because it's not absorbed. It's not good for that, okay? All right. So let's now go and do a little discussion on this. Let's talk about, once again, we're going to break down our rashes by ages of the patients. And we're going to look at the patients from birth to 2 months of age. Is it a generalized rash or is it localized? Well, let's look at generalized rashes, and this is your differential. Okay, could be herpes. These kids look pretty sick. Okay, erythema toxicum. This is a very common one to get asked. Not present in the first day of life. Not present in the first day of life. Okay, usually starts after 24 hours of age. It starts out as an erythematous rash. It forms a macule, then a papule, then a vesicle, then a pustule. It's a migratory rash. It's all over. And I have a picture coming up in a minute. The really key ingredient here is the patient looks great. This is not staphylococcal scalded skin. This is not epidermolysis bullosa, where they're blistering up and sheets of skin are just falling off. No. These kids look really healthy otherwise. And it can last a couple of weeks. It's basically the baby's immune system just showing off. Okay, so here we see erythema toxicum. You see a little bit of like a little vesicle right there, okay? And you see a lot of little ones, okay? And some erythematous areas. Not a big deal, okay? And if you don't even need to scrape these, there's the eosinophils there. You don't need to scrape it. Again, it's a clinical diagnosis. No need to treat. Correct. No need to treat. Reassure the family that it's going to go away, that there's nothing to do. All right. So you can have congenital varicella. You can have, and that's, again, these kids sometimes have limb deformities with congenital varicella. Staphylococcal scalded skin, like I said, Nikolsky sign, very sick-looking child. Okay, here is it. Look at that bullous lesion right there. Look how all of these blisters have popped. This is serious business. This is staphylococcal scalded skin. These patients look sick. They act sick. They need IV fluids, IV antibiotics. They can be septic. They can be in shock. And there's somebody showing you Nikolsky sign.